So I'll give a talk on propagating uncertainty across cascading medical imaging task for approved deep learning inference. This work is done in collaboration with my colleagues Thomas, Tanya, Paul, Dr. Arnold, and Professor Arbel. So let me give you an introduction. So generally in a medical imaging task, we have a cascade of inference task before we do the downstream task of interest. Let's take an example of multiple sclerosis disease activity prediction. So in multiple sclerosis disease activity prediction, we try to see if a patient at time point T is going to be active in the future or not. So in a recent paper, it was shown that this is highly correlated with lesion segmentation, and it was shown that if we have a lesion segmentation available, we can do this task in a better way. So if we consider it as a cascade of inference task, the task of interest are registration, skull stripping, the T2 lesion detection, and activity prediction. So for all these four tasks of interest, there has been some paper which has said that deep learning method works good for that. So, but one of the disadvantage of deep learning based method is that they only provide a deterministic output. So if we make a mistake for one of the tasks in the initial task like skull stripping or lesion segmentation, it can hinder the performance on the downstream task of interest, which is here, lesion activity prediction. So let's look at one particular example of T2 lesion segmentation. So recently, last year, a paper was proposed in MICCAI 2018 of Bayesian unit. So in that, if we just get the inference out of that Bayesian unit, we see that network is making mistake here because it is identifying a false positive. So if we, the method Bayesian unit proposed that if we can get uncertainty estimation with it, then it can be correlated. So this uncertainty estimation was done using Monte Carlo dropout. So in Monte Carlo dropout, you pass the same input through network multiple times, you get multiple Monte Carlo samples, you apply a function on top of it, assuming that, let's take an example of variance. So we take the variance across Monte Carlo samples and we get inference and uncertainty associated with that. Okay, sorry, so here it's not clearly visible, but please believe me that there is uncertainty, higher uncertainty for false positives. It's not visible here, sorry. So it shows that uncertainty is indeed correlated with the error which the network is making. So here we use Monte Carlo dropout to get the uncertainty. There has been different methods which has been proposed to get uncertainty. Some of them are really popular, like probabilistic and symbol, etc. I won't go into detail of them, but all this method has been used for different medical imaging tasks like modality synthesis, registration, classification, lesion detection, etc., etc. So I won't go into detail of these all papers, but to summarize them, I can say that all the papers report that areas where network is prone to make errors, we get higher uncertainty, and similarly, if we just evaluate the performance as the most certain prediction of the network output, we get higher input performance. So this is all good and says that okay, we can use uncertainty estimation for get a better performance, or can be used for clinician use. But can we indeed use to improve the downstream task in different cascading medical inference tasks? So that is what we are trying to do in this paper. We propose a framework where we say that we get uncertainty and inference from one task and propagate it to the other task and try to see if the network performance improve or not. We evaluated this on two different tasks of lesion segmentation and brain tumor segmentation. I'll go into more detail of each of them now. Let's first take an example of T2 lesion segmentation detection. So as we saw in the previous slides that indeed we get uncertainty, higher uncertainty for when we get network is making mistakes. So for in this task, what we are trying to see is that if we can leverage this to further improve the same task of interest. So here there are two tasks of interest, task networks. Task 1 network is a Bayesian unit, task 2 network is a 3D unit. Both tasks are for lesion segmentation, which are further converted into detection. And we use Monte Carlo dropout to estimate uncertainty from Bayesian unit, which is a task 1 network. So in terms of dataset, we use a proprietary multiple sclerosis dataset, a multi-site dataset. We have 5,800 MR available and T2 lesions expert label available. From this dataset, we use 40% of the data for training and validating Bayesian to train and validate 3D unit and 10% to test the 3D unit. So now here you can see that in expert labels, when there is a lesion, sometimes we don't get the whole lesion marked, but we can say that lesion is detected. As a lesion detection has been shown that it is highly correlated with downstream task of interest of activity prediction, we convert this segmentation into lesion detection by lesion connected component analysis. We divide these lesions into 3 different subtypes: small lesions, medium lesions, and large lesions. Please note that small lesions are most hard to segment because they are 3 to 10 voxels, but 40% of the total lesions are small lesions. So it will be good if you get higher performance in small lesions. So for all these lesion types, we plot receiver operating curves, we calculate area under the curve for them, and we also report true positive rate at false detection rate of 0.2, which is a clinically relevant point according to the clinicians. We use 2 different baselines to compare if our method is good or not. First method, baseline one is where we don't have a task or network, here a Bayesian unit, and we just have a task or network which is 3D unit. So this will allow us to see if indeed cascading to same network helps in getting better lesion segmentation or not. In the second baseline, we just get inference from the Bayesian unit, and we just pass the inference through to the 3D unit. This will allow us to see if indeed propagating uncertainty is useful or not. So now let's look at some of the quantitative results. Here, yellow represents baseline 1, where we don't have a Bayesian unit. Blue represents baseline 2, where we just propagate inference through the network from Bayesian unit to the 3D unit. And pink represents the proposed framework, where we propagated both inference and uncertainty to the 3D unit. Here we can see that in terms of AUC and in terms of TPR at 0.2 FDR, we get higher performance for the proposed method compared to both baselines. So this indeed shows that uncertainty propagation is useful. We do the same, we also report it for the small lesions, and we see the same trend for that, where we get better performance with propagating uncertainty through inference task. Let's look at some of the qualitative results. So first column represents T2 weighted MR images, second column represents ground truth, third column represents the lesion segmentation detection achieved from Bayesian unit, fourth column represents the uncertainty, and fifth column represents output of 3D unit when we propagate both inference and uncertainty. So for first 2 row, we can see that network is getting 2 false negatives, but okay, in this also uncertainty is not visible, but believe me, please. Network is uncertain about it, and 3D unit is able to correct it and get converted into the true positives. In the third row, we see a false positive, and we can see that, okay, I guess this way we can see here that there is uncertainty here. So we can see that there is uncertainty, and it allows the network to correct its mistake and convert into a true negative. So in this way we can see that both qualitatively also we are getting better performance. So now we will look into the second pipeline. So till now we just looked into brain MST to lesion segmentation, where both tasks were of the same. So in this we try to look if 2 networks, when 2 tasks of interest are different, how the network performs. So the task of interest is accurate multi-class tumor segmentation in case of missing modality. Task 1 network is a regression segmentation network, which synthesizes the missing modality with the available modality. And task network is a 3D unit for multi-class tumor segmentation, and we use another 10 Monte Carlo dropout to estimate uncertainty in the first task. And we use publicly available brain tumor segmentation dataset for experiment. This has 3 classes as a ground truth: edema, enhancing core, and non-enhancing core. We use BROAD's 2018 rating dataset to train and validate RSNet in 3D unit, and BROAD's 2018 validation set to test the 3D unit. We follow the same protocol used by BROAD's challenge by calculating die scores for 3 tumor subregions. Similar to the previous pipeline, we use the same baseline where in baseline 1 we don't have a task 1 network. Here regression segmentation network, so it means that we don't synthesize the missing modality, and we just segment using the 3 modalities available. So this will allow us to see if indeed synthesizing the modality was useful or not. In baseline 2, we just propagate the inference from task on network to task to network. This will allow us to see if indeed propagating uncertainty was useful or not. So as I say that in brain tumor dataset we have multiple modalities. So these modalities are T1, T2, T1C and FLAIR. And if you look at the synthesis of this modality using other available modality, we can see that for T1C and FLAIR we were making more mistakes and uncertainty was higher for that. So for this work we just follow this paper's output and we see that we just do experiment on T1C and FLAIR synthesis. So if in terms of quantitative results, if you look at this, we see that we get higher performance when we propagate uncertainty compared to when we don't propagate uncertainty. So this shows that yes, indeed, propagating uncertainty was useful. This is the same case for FLAIR synthesis, and we get the same kind of trend where propagating uncertainty was useful. Now let's look at some of the qualitative results. So first row represents the ground truth, second column represents the synthesis MR, third column represents the segmentation when we just propagate inference from task to network to task to network. Fourth column represents the synthesis uncertainty, and the fifth column represents when we propagate segmentation when we propagate both inference and uncertainty. So here we can see that a network is synthesizing T1C, but it is not clearly properly synthesized. So this makes segmentation network to make some mistakes. But if we look at the synthesis uncertainty, network is also saying that yeah, okay, I'm not also sure if I have synthesized properly or not. So when we use both inference and uncertainty, network is able to correct some of the mistakes and it gets better segmentation. Similarly, in the third row, we can see that when we synthesize FLAIR MR images, we get hyperintensity within ventricles, which is normally not the case, but this leads to edema being segmented inside ventricle. And when we look at the synthesis uncertainty, it is higher, so this will allow the network to see if it can correct it, and indeed it corrects it. So this shows that yes, propagating both inference and uncertainty indeed is useful. So in conclusion, I can say that we proposed a general framework for propagating uncertainty across sequence of medical imaging tasks. We evaluated it on two different tasks of MS lesion segmentation and brain tumor segmentation. We saw 2 to 10% improvement for both tasks in terms of quantitative results, and clearly visible qualitative results were shown. And in future work, we would like to make this an end-to-end system. We would also like to see if we can get uncertainty in different methods, like probabilistic unit or something. Thanks.
Do we have any questions for the speaker?
In the BRAT example, when you generate the missing modalities and then you get an uncertainty, did you find that the uncertainty correlated well with the information that was missing in the missing modalities? So, for example, the T1 contrast contains like fundamental information about the tumor that's not captured in the other modalities. Like, did you find?
T1C normally shows enhancement within the active tumor, which is not present in other modalities. So it was making mistake, but we found that yeah, it is able to synthesize and having a higher uncertainty for that. I'm not sure if it is.
Yeah, it's just.
Any further question? Actually, I had one question. Did you compare, for instance, for your first task, when you were looking at the MS lesion, and you had maps of uncertainty before, so after the B unit, and at the end, did you compare the uncertainty maps that you obtained, and what did you gain from it? Or if you did, what did you gain from it?
So yes, these uncertainty maps are from the Asian unit.
But at the end, do you get as well an
yeah,
uncertainty map?
we did not compare it.
You didn't?
We did not compare it.
So let's thank the speaker again, and we will move on to the